All right. Oh, well, I'm sure a bunch more people will trickle in, but let's get started this morning with the Survivorship Lecture Series. Today we have Marleah Dean Kruzel, PhD, who's an associate professor in health communication at the University of Southern Florida and a collaborator with the Health Outcomes and Behavior Program at Moffitt Cancer Center. Broadly, her research investigates how communication can improve health outcomes and experiences for different healthcare stakeholders. But she is an expert on the health and experiences and decisions of previvors, who are individuals with inherited gene mutations who have not been yet diagnosed with cancer. As a BRCA2 previvor herself, she's committed to patient engagement and translating research into practice. And today she will talk to us about interpreting the digital media. I'm very interested in her talk. So Marleah, go ahead.
Thank you so much for that introduction. I appreciate it. Yes, good morning from Tampa, Florida. It's a pleasure to be here on behalf of FORCE, Facing Our Risk of Cancer Empowered. As was shared, I am a professor. My research expands the cancer care continuum, but really focuses on health communication, medical decision-making, and communication of genetic risk information. But today I'm going to be talking about digital health information and media coverage and its impact on patients. So let's dive in. So as I just mentioned, this presentation is a joint effort between the national nonprofit FORCE and several other partners, including myself at the University of South Florida. Just for some background, you likely already know this, but FORCE is the only national nonprofit organization that serves people and their families affected by hereditary cancer. And their efforts really span a wide range of social support and advocacy, as well as research and education. And this presentation is one example of that intersection. Before I begin, I'd like to note that this work is supported by the Centers for Disease Control and Prevention. And like I said, it's been a collaborative effort between USF and FORCE, as well as several other partners, the Susan G. Komen, National Society of Genetic Counselors, and the Academy of Oncology Nurse and Patient Navigators. And opinions expressed in this presentation are our own. So here's a kind of a brief overview of the objectives or things that Sue Friedman, the executive director of FORCE, and I hope that you take away from this presentation. We're really going to be diving into digital health literacy. Likely you are a little bit familiar with this in terms of health myths and disinformation that you see in your everyday lives, as well as caring for patients. And then we'll also talk through some communication tips and resources that we hope will be helpful as you interact with your patients as they dissect and try to understand digital health information. So we'll start off by really diving into what is health literacy, what is digital health literacy, and how that's connected to jargon and plain language. So when we often think of health literacy, we often think of it as a label for people, right? When we're speaking with a person, we may say something like, this person's being health literate, or this person has low health literacy. But these labels can be stigmatizing and can put the blame on the person. So for example, in the graphic that you see here, you see the patient who is a little bit confused about what their physician is saying, and thus they might be labeled as someone who has low health literacy. But as you see in this graphic, the definition of personal health literacy includes the use of or access to care. And so what we have started doing is taking the CDC's newish term, organizational health literacy. And what they've done is really added organizations to the definition and trying to take, acknowledging that the sole burden of health literacy and understanding and applying health information and making decisions should not be on the sole burden of the patient. So this revised definition really acknowledges the importance of health equity and how organizations have to be a part of the solution in order to remove existing barriers and disparities when we think about health literacy. So I am curious, and as I was talking when we first started this presentation, I can't actually see the chat when I'm presenting, but I would love it if you would be so kind as to just put in the chat so we can kind of get a sense with each other if you have heard of organizational health literacy before. So just in the chat, give a yes or a no. Great. I see that some people are typing. I appreciate that. I can't see what you're typing, but I appreciate the participation. At least you'll be able to all see each other.
We've so far got 5 no's, Marleah.
Great. Thank you so much, Debbie. All right. So then let's transition to thinking about digital health literacy or e-health literacy. So, as we know, the increasing use of digital tools and communication in healthcare really necessitates better communication between healthcare providers and patients. And one way is through digital health literacy. This has especially been true since COVID-19 and the increase in telehealth, as I'm sure probably resonates with you. Definitionally, digital health literacy is an individual's ability to seek, understand, and assess electronic health information, but then apply that knowledge gained to address some type of health issue or problem, right? So in our context, cancer. Now, you'll notice that this definition is kind of similar to personal health literacy, but there are some specific traps or particular challenges for patients that cancer patients in this digital space. And I'm going to discuss those in a little bit. But just to kind of show you some of the differences between this definition and personal health literacy, we have number one, we're finding information online versus, in the world, talking to family members or friends. Assessing that information, the accuracy as well as the relevancy to one's situation, and then the ability to even apply that information. So these are some of the differences between those two. Now, while there has been an increase in digital health research in the healthcare field, health literacy and jargon are still top barriers to healthcare services. This is just one example that Force conducted along with this project extra supported by the CDC. And in 2020, we performed a series of different needs assessments. We queried genetic counselors, oncology nurse navigators, and then community health workers. And we asked them, along with a lot of different things, but the barriers to referrals to different specific services. And we asked them to select up to 3 top barriers to referrals for each service. Now, they could also choose no, to be clear as well. Now, when it came to clinical trials, of the respondents who indicated that they had referred to that service, as you can see in this graphic here, jargon or health literacy was still a very important barrier to referral. So let's think now about what are some factors to digital health literacy. There are several different factors that we have come up with, and here are just a few examples. These things would be impacting someone's ability to find, understand, assess, and apply that information they find online. Number one, it could be personal factors such as identity. Are you single? Are you in a relationship? Even the images chosen for certain brochures that might be available in clinics or in hospitals, that might impact how a patient feels about the information. Family and work, right? If you're caring for young children at home, do you have to arrange for childcare in order to see a doctor? If you are employed full time, will you lose a whole day of pay in order to go to an appointment? We can also think about education. But health literacy is not only about how much school you completed, right? Someone with an advanced degree, even myself, as a BRCA2 previver, and when I go to the doctor, there are a lot of times that I don't understand some of the technical medical jargon that's going on. Your emotional state, your situation can also impact your ability to absorb information. If you've been diagnosed with a medical condition, right? You're recently diagnosed with cancer, you have that breaking bad news. And as a patient, you can really feel like it's a fire hose of information. I remember my mother, she's a breast cancer survivor, 25 years, and she always described when she was diagnosed that she felt like she was being dropped in the desert, in the middle of nowhere with no resources, because she just didn't understand what was going on. And it was so emotionally, it impacted her emotionally. Then we can also think about environmental factors. So where you live can affect your access to care. Do you live in a city with large hospitals or universities, or do you have to drive hours in order to see the nearest doctor? And then lastly, another thing might be social support systems, right? Do you have a support group to help you with the treatment of cancer? Are these social support systems, are they trustworthy? Are they experts of certain topics? So these are some factors that might help you kind of think through digital health literacy and how it might impact patients. Now, there's another way to think about factors that can affect digital health literacy, and those are the social determinants of health. So I'm going to talk through what those are. These are conditions in the places where people live, learn, work, and play that affect a wide range of health risks and outcomes. Now, the example that you see here in the figure, this is the version issued by Healthy People 2030. And it outlines really 5 domains. So we've got economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and then social and community context. So what I'm going to do now is I'm going to walk you through each of these different social determinants of health, and we can see how that might be impacting patients. So in terms of economic stability, here's some of the examples that we came up with. So things that could be impacting. Ability to take off time from work, like I mentioned earlier. Perhaps the cost of mobile devices or computers or internet services, right? And that ability to find or access telehealth information. The cost of health insurance, office visits, medication, and other types of care. And then let's not forget access to reliable transportation to even get to the appointments or to participate in a clinical trial, for example. Here's just one example that we found. This was a study that was published in 2021 that looked at out-of-pocket costs for high-risk women who've received breast screening MRI. And the authors found that while many women are subject to high financial burden when receiving MRI for breast cancer screening, those enrolled in high deductible plans who reside in the South are especially vulnerable financially. So again, we kind of already start to see the intersection of different social determinants of health in just one example. Now, since we have lots of different partners on this project, one of the things that we said we would do on behalf of our advocacy partners is to share, as we talk about each of these different social determinants of health, is one organization or one resource that might be helpful for you as you care for patients that might help address these barriers. So as you can see in this slide here, this is Cancer Care. And this is an organization that offers financial assistance for cancer-related costs, such as childcare. And they are one of many different organizations that offer these types of programs, but this is just one example. So let's think about education access and quality now. So again, some things that we've thought of, grade level reading skills, numeracy, right? Understanding statistical concepts like risk, critical thinking skills, understanding of research process or formulation of guidelines, how those national guidelines come about, and then access to computers and technical skills. For example, as you see here, some of the research that has been done on this shows that students and healthcare providers actually perform similarly in distinguishing between true and false studies. So the key really is to have that analytic ability to distinguish between them. However, in this study, both people in both those groups believe that stories are true if they align with existing narratives. So again, we see an intersection between these different social determinants of health. We also think it's important to note that people who face these types of educational access and quality barriers often lead to missed appointments, which can lead to then not following medical instructions. And that could simply be because they don't understand. But oftentimes, when that happens, they are labeled as non-compliant patients. And this is problematic. Here's a quote from one of our partners, the Tiger Lily Foundation. And she really talks about how that patients are often afraid that they will be labeled as difficult, and so they don't speak up. So it's important to further expose these issues of bias and discrimination. So here's one resource for you. This resource might help address the barrier of education access and quality, and it's called the Patient Empowerment Network. And they've developed their digital Sherpa program. And this is really to pair older adults with cancer with students, college students, who can help them develop their digital skills, which can include the following: setting up an email, how to access their patient portals, and then how to find social support services online. Let's look at the third social determinant of health. So this would be healthcare access and quality. Some factors that might affect digital health literacy and health literacy broadly. So providers who know medical history and can provide personalized guidance, access to patient portals and details about test results, diagnosis, recommendations, coverage for specialists or specialty services, maybe the proximity to comprehensive medical centers or cancer centers, access to adequate pain management, or perhaps access to newer therapies. As you see here are just two examples of how healthcare quality and access can affect people's care. Now, there have been multiple studies like the one that you see on the left here that show that in states with Medicaid expansion, cancer mortality goes down. And it makes sense that the more people who are able to get health insurance, the more likely they will be able to get life-saving services as well. The article on the right is one of several that has found bias plays a role in people's access to pain medication, and also how physicians' beliefs about how Black people experience pain can lead to inadequate pain management for Black patients. Here's another example. This visual shows states in orange that have Medicaid bans on transgender care. And if you live in one of these states and have Medicaid and you are transgender, you will not be able to receive gender affirming care. So how do we address this? Here is another example of a partner who tries to address this issue. Our partners at Triage Cancer help people find affordable health insurance plans, and then they can assist with appealing if their insurance denies coverage for a specific service. All right, stay with me a little bit longer. Two more social determinants of health that we'd like to share with you. Again, some factors that we think might impact from social and community context. So it could be where you worship, your religious background or context, your family experiences with health and disease and cancer. Cultural factors, these could affect lifestyle and healthcare decisions as well. Perhaps the places you go or where people gather and they have opinions about community, so trusted community leaders. And then also maybe where you go for peer support, your social network more broadly. These things can influence and impact the type and accuracy of health information that you might receive. I want to point out here that the quote on the right is from an advocate from the National LGBT Cancer Network. And this happened during a session about equitable care at Force's 2022 conference. And the quote really emphasizes that when people are faced with a non-supportive or even hostile environment, they might be reluctant to reach out and access care. And this is especially if the unsupportive environment comes from the healthcare community. So here are two resources we'd like to share with you that might help address these social and community context factors. The first on the left is a partner, The Beautiful Gate. They bring mammograms directly to people in their community. Their MASS program Mammograms after spiritual services includes education about the importance of mammograms, and then allows people to sign up for mammograms right after their church services. And this is happening especially in rural areas in Florida. The second one is Force, a resource from Force specifically. They have a closed Facebook group, and they have trained moderators who try to help regulate and make sure that misinformation is not spread through the community, but also offers that ability to build rapport and have social support within a safe place. The last social determinant of health, neighborhood, and built environment. So some factors that might affect health literacy here could be access to reliable internet, access to a library, digital library resources and books, proximity to healthcare services, transportation, clean water, clean air, local parks or sports complex, and food deserts. As you see in this image, food deserts is making it hard for people to, or can make it hard for people to follow nutrition recommendations. Or imagine if you are, as a patient, reading an article on the health benefits of fresh fruits and vegetables, but then imagine that your closest grocery store is 20 miles away and the cost of fresh produce is unaffordable. But here is an example of one resource from our partners who provide direct services to people diagnosed with breast or gynecological cancers. Unite for Her provides a coupon box which people in treatment can use to have fresh fruit delivered to their home. So what can we do about it? Next, I want to share with you some communication tips and strategies for thinking about health literacy. And the first simply goes back to my point about organizational health literacy from before. You can be a champion for plain language. You can remind your colleagues to use strategies such as active voice, making things personal with the use of you. You can review patient-facing information, encourage organizations to use short sentences and paragraphs when they're creating brochures or patient-facing materials, use everyday words, and then reassure your colleagues that plain language is not necessarily condescending or childish or dumbing down information. A second strategy, you can engage in the teach-back method. And I'm guessing that you are likely familiar with this method. But just to quickly review, the teach-back method is a well-known strategy and is taught and promoted through medical schools and public health service agencies. And you may already use this method in your clinical interactions, but you can help your patients by encouraging your colleagues perhaps to use this method as well. The flyer resource on the right-hand side is from the Agency for Healthcare Research and Quality, and it's a really helpful resource for patients. It really talks about how to be proactive as a patient, telling the patient what the teach-back method is, and then how you can use it together in order to communicate important information. Another helpful strategy is the Ask Me 3 model, which provides a clear structure for how to gather, process, and understand health information. And you can do so by, which then enables you to empower your patients. This model teaches that at the end of every visit you have with a patient, the patient should ask 3 questions. What is my main problem? What do I need to do now? And why is this important for me to do? And the idea is that if the patient can't answer these questions at the end of their visit, then it might be important for them to ask some follow-up questions to make sure that they understand what has been communicated during that interaction. And you can teach this method to patients as well. And you'll see the resource on the right-hand side. Fourth, you can keep in mind that people have preferences about language. So here's just one example we wanted to share with you. A consortium of advocacy groups, including Force and industry partners and professional societies, created the Consistent Testing Terminology Working Group, and they conducted a In 2019 and 2020, they conducted a survey with patients to learn about their preferences for language to describe genetic testing and mutations. Now, this was a part of a larger effort to really try and reach consensus about language when speaking to patients about biomarkers and mutations. And they found that the survey was deployed, I should say, by over 15 advocacy groups across many different cancer sites. And participants included people with cancer, as well as people without cancer, people who had genetic testing and those who did not, and people who had tested positive and those who were negative. And as you can see from this figure, results were pretty similar across the groups. By and large, people prefer genetic testing for an inherited mutation or genetic testing for cancer risk information over germline genetic testing. Now, interestingly, the group also received a lot of write-in comments, about 1,500 write-in comments about preferences for terms. These are just a few quotes that we wanted to show you to give you an example. But overall, people commented over and over again that they felt like inherited mutation and genetic testing were the best plain language, and that was their preference for terms. So now that we've explored the social determinants of health and how those might impact health literacy and digital health literacy, and then we've talked through some general communication tips and resources, I want to change gears now and really focus down into what I mentioned before about those traps or challenges of online health information, or things that make online health information difficult for patients to navigate. So as we know, a large majority of patients use online resources and information to access information about cancer. While seeking health information can be empowering, there are concerns about possible consequences for searching and following medical advice found on the internet. We've compiled a list of 8 that you see here that reflect many patients' experiences when searching for health information and draws on literature within this space as well. So I'm going to go through each of them for you. So first, patients often report contradictory information when using the internet. For example, the article on the left and the article on the right are coverage of the same peer-reviewed journal article, but with 2 completely different messages. Now, this is problematic because people might react differently when confronted with this contradictory information. Some might assume that they're the same, they're equivalent. Others might ignore it, and others might just give up. A second trap is extensive. As we know, the internet has so much information and it can be very overwhelming. In less than a second, you can get access to over hundreds of millions of pieces of information on cancer. And furthermore, search terms, or search tools, I should say, do not necessarily list the most credible information first, right? So then you have to go through and sift and try to identify what might be accurate or relevant to you. A third challenge is online health information is often sensationalized. On the left is just one misleading article, which had patients with advanced cancers telling their physicians that they were planning to travel to Israel for treatment. But this article was in the Jerusalem Post, and it was later picked up by other outlets. And it was in an interview with 2 scientist entrepreneurs who started this company. They had no human data, no peer-reviewed publications, and neither scientist was an expert in oncology. And 2 years later, still nothing has come of this research. The fourth is accuracy. In some cases, either on purpose or inadvertently, the media can get the science wrong. And this is just one example. You can see that this headline is wrong on several accounts, which is listed on your right. Another trap is lacking expert review. Online health information is often delivered by people claiming to be experts, but they are not. They might be celebrities. And as we know, adding a celebrity name to a health product can increase popularity, but often that information being shared is not necessarily reviewed by experts. So online health information, especially in unmoderated social media sites, can spread misinformation very quickly. Here's another, that would be lacking context. So media articles oftentimes lack background information, and it's important to understand, that's important to understand in order to understand what the information in the research is about. So in this example, the media report suggests a direct link was found between Alzheimer's disease and having a BRCA mutation, which is the mutation that Angelina Jolie has. And although the researchers studied the brains from people who died of Alzheimer's, it was mostly conducted in mice. And this study was not designed to show having a BRCA mutation causes Alzheimer's disease. Instead, it was looking at a new model for understanding Alzheimer's disease. But again, we can say that this is an example of research that's out of context. Another trap is jargon and inaccessibility. So while accurate medical information may be in our peer-reviewed journal articles and thus is usually reliable, they are hard to read and oftentimes full of medical jargon. Furthermore, as a patient, if they start Googling and finding peer-reviewed journal articles and trying to get access to those is difficult because there's usually a paywall, right? They have to pay a fee to read those articles. Now, they might have access to the summary or abstract, but nonetheless, they can't get access to the whole. All right, the last trap is confirmation bias. Confirmation bias, it is what happens when you see the same information multiple times or in multiple settings. And people who are more likely to believe information if they see it multiple times, right? So these are just two examples of pieces of confirmation bias in action. Now, because of how the internet is set up to reward traffic to pages and sites, some search engines and social media companies have set up their sites to show you more information based on what you've searched in the past. And this is called retargeting. All right, so we just talked through a lot of different traps of digital health information. But I'm curious if you could share in the chat with each other, which ones do you think, or which one poses the most harm to patients? Most harm to patients. So if you could add that in the chat for me, please.
I don't see other responses yet, Marleah, but I said all of them.
All of them. Okay, yeah, absolutely. I think it kind of depends on the stage of the cancer patient's journey, and it depends on multiple factors, right? So let's talk about this a little bit further and apply your knowledge and your experiences perhaps that you've had. So as we've discussed, media often go for those eye-catching headlines and graphics, but those do not always match what the article is actually about. In fact, sometimes they exaggerate, right, in order to get people to click on the article, called clickbait. So I want to do just a couple slides here, and I want to show you how much of a mismatch is there between peer-reviewed, or can be between peer-reviewed journal articles that you might see in your professional circles, and then the media coverage that patients see. So here's the first one. So at the top, you see a peer-reviewed journal article for you. Expression and functionality of TRPV1 in breast cancer cells. So one of these three media articles, think about which one of these three media articles corresponds to that peer-reviewed journal article. Again, this is meant to challenge us a little bit in how much there's a mismatch, but take a guess. Is it coffee may improve survival after breast cancer? Chilies can help beat cancer as research finds, and antioxidants are good for you. And you can take a second to think about it, maybe throw it in the chat if you'd like to share it with your colleagues on the call. Give you another minute. All right, the correct answer is B. And looking at the title, people might conclude, patients who are seeing this might conclude that eating chilies can help us fight cancer, right? But that's not what the research is all about. Let's try another one if you don't mind. Which media do you think goes with this peer-reviewed journal article? So at the top we have gaps in incorporating germline genetic testing into treatment decision-making for early stage breast cancer. Is it A, stunning allegation, half of all mastectomy patients do not have cancer gene, misreading data? B, nearly half of at-home DNA test results could be wrong. Or C, once again, we see the Angelina Jolie effect, prophylactic surgeries nearly double in men with breast cancer. Again, take a minute, think about it, maybe throw it in the chat, share, see what your colleagues think. All right, the answer is A. The words stunning and allegation are not found anywhere in the scientific journal article, and the media really totally mischaracterized what the researchers concluded. Okay, so we know that patients are going to consult Dr. Google. We know that they are trying to decipher and understand and apply this health information they're finding. But let's now talk about resources designed to improve patients' digital health literacy, which perhaps you can share with your own patients. The first resource is from the Office of Surgeon General, who created a toolkit for addressing health misinformation. You can see the link at the very bottom. And I know this is being recorded, but I'm happy to share the slides as well, because I know we're going through a lot of resources. The second resource is NewsGuard, and this is a really interesting one. It's a subscription service that provides a nutrition label for websites by helping people see how transparent and accurate the websites are and who owns them. So, for example, on the left, you see one of the headlines from our matching activity that we just did about antioxidants. And then you'll see lots of problems with that one. And then on the right, you will see this is in contrast to the CDC, which got 100% score from NewsGuard. Another thing that we think is important to consider, especially within your professional space, is press releases. So even more reliable organizations and websites can release sensationalized or hyped press releases. We know that universities might want their donors to know that their center is conducting groundbreaking research, but often that research is early. And press releases that even come from academic institutions like ours do not have the same degree of review as a peer-reviewed journal article does. This is just one example of that. We see the Columbia Journal review from 2013, and it showed that 44% of reporters interviewed said that their organization ran stories based primarily on press releases without doing any additional background or fact checking. Finally, a somewhat newer phenomenon is journals claiming to be peer-reviewed when they're not. So again, it's really important to be careful what you're reading and making sure you're getting your medical information from accurate sources. So given this research and resources, Force created a tool to help people improve their ability to fact check and be more savvy consumers of health information. So I'm going to share with you two last resources that we hope will be helpful for you. This is called Spot the Boast, and this draws on research and many traps of online health information that we discussed earlier. And BOAST is an acronym, which I'll tell you in a minute, but it is designed to help people avoid the red flags of online health information. And here's a QR code, and again, we'll share this with you. Basically, the program provides patients with tips to help them look more closely at the source of health information, the content, what the information is about, and then figure out what the relevance of this information is for their specific situation. What's great is the website provides specific tips for checking that they can save. And then here is what BOAST stands for. And of course, hoping that the acronym helps people remember things. So is the information biased? Is it overblown? Is it involving an amateur, sales focused, or is it taken out of context too soon to be useful? The program also includes a built-in knowledge check, and it makes it fun and interactive for people. Here's just one example question, which provides an explanation for why an answer is right and why one is wrong, so patients can test themselves. So why don't we take a minute and see what you think? Let's test your knowledge. In the chat, again, if you don't mind, or you can self-reflect too, write which boast example you think this is. So here is the media piece on the right for you, from a fictional Me Tube, and it's former TV personality who cured cancer himself. Do you think this health information is biased, overblown, amateur, sales focused, too soon to be useful, or taken out of context? And I'll give you a second to think it over. So the answer is C, amateur. All right, I see we have just a couple minutes left because I want to make sure we have time for questions. So I am going to end with you sharing one last resource that was designed by Force called the X-ray program. And this may assist you in facilitating future conversations with your patients about digital and media health information. Now, X-ray was initially developed as a part of a different cooperative agreement than I mentioned earlier from funding from the CDC. And the main goal was to address misconceptions and misunderstandings presented in the media about cancer health research. So these are the cancers that the X-ray program covers: breast, metastatic breast cancer, colorectal, etc. And basically how the program works is it examines peer-reviewed journal articles, which you see on the left, as well as then the media reports that come out on the right that are related to those scientific articles. And then it tries to translate that information into patient-friendly, plain language so that patients can understand really what this information means for them. So let me walk you through just one example. The journal article on the left describes a laboratory research study that was looking at an amino acid and then the effects of feeding massive amounts of this amino acid to mice with breast cancer. Now, this was very early research. It had not yet been applied to people, and the goal was simply to find and study new targets. Yet what we see on the right-hand side of your screen is that the media covered the research with the headline, "Bunk this veggie," telling people to stop eating asparagus. And that's not at all what the research was designed to tell, and it was not what was concluded. So in contrast to the scientific media reports that you saw, this is our X-ray program review for the topic. Like I said, it provides plain language, gives a relevance score, a strengths of science score, and then the research timeline as well. They also, X-ray also, or Force through X-ray also tries to rate the coverage of the science. If they did a good job covering it accurately, they provide them with 5 stars, a nice visual for patients. They take away the stars if they didn't get it right. So for example, in that "Bunk this veggie," only 1 star was given for their research coverage. They didn't do a very good job of accurately sharing what the information found. There's also links to clinical trials that are related to the specific research that they're sharing, especially for those in early clinical trial results. People who want to know about how to get access to these new promising drugs that might not have been approved by FDA. So they would go through a clinical trial. So they try to give that information and provide related resources in other organizations that might be helpful for patients. Finally, the Force indexes the articles so that you can search them by topic, cancer type, and who it is relevant for. All right, I know I went through a lot of content and a lot of resources, tips and strategies. So I'll just wrap up by telling you a few takeaway messages that Sue and I have come up with. First off, we want to reiterate that health literacy really is a crucial part of communicating about health, especially in the cancer context, especially in today's climate with digital health information. And we can all play a role in improving health literacy, both personally and through the organization. Second, there are features unique to digital health literacy that really make it particularly challenging for patients to navigate. So, we encourage you to help your patients spot the tracks of online health information and address the wide range and spread of misinformation. And then finally, we hope that the resources we've gathered for you here will help you assess and address health literacy and digital health literacy of your patients, and hopefully ultimately work to empower patients and improve their health outcomes. Here is a complete list of all of our partners. We could not do any of this work with all of our partners listed here. And then lastly, if you would be so kind as to give us some feedback, I will drop this link in the chat for you so that you can give us feedback on this presentation as we continue to help others. Thank you so much.
Great. Thank you, Marleah. That was a wonderful talk. Very information packed. I encourage everyone to look back on this. Everyone's saying thank you. This was really wonderful. I think what resonates with me with patients is that language barrier, which is affected by all these different things, right? And
Yep.
it's not just the media and research articles using poor language, but then doctors as well, and what we
Yep.
how we translate things and interpret things and tell them to patients. It's all over. So
yeah. I'm glad. I'm happy to answer any questions. I know it's a lot of information. Normally, this workshop is a little bit longer and a little more interactive. So
yeah.
perhaps it actually felt like a fire hose to you. I don't know, but we're happy to share the PowerPoint as well.
Yeah, that would be great. And yeah, we might bring you back, as a survivorship, really do a more interactive workshop. That would be, I could see how this could be like a much bigger event and would be great. And we could get people involved. Does anyone else have questions? I didn't get any questions. Just thank you and positive feedback in the chat.
Okay, I can see the chat now. So I'm just going to put my email in there. If anybody wants to follow up with any emails or have questions, feel free to reach out to me as well. And I also put the link in the chat. We would greatly appreciate it. It helps us evaluate our program. If you could take just 5 minutes of your time to complete that link, we would appreciate it.
Yeah, there is a newsletter from Force with get the x-rays in my inbox,
Yes. Yeah. It's great. I think it's helpful for both the healthcare providers, but also the patients.
It can be, definitely. And these are great resources, all these things that we should be using a lot more with our patients. So I encourage everyone to do that. And we should maybe have a talk more about how we can engage our patients more with these tools, because it's great to have the tools, right? But getting patients to be aware of them. And yes, that comes in Spanish too. Thanks, Vivian.
Yeah.
Our resident genetic counselor on our survivorship team, that these are great resources for patients, and for especially patients counseled about genetic cancer mutations. So
yeah, no, you make a great point. These are great resources, but we also acknowledge the complexities around communicating with patients in a clinical interaction, and there's only so much time, and there's lots of factors that play into that. So we would love to come back and maybe have a more in-depth conversation about how it might be feasible or helpful for you to use some of these resources within your spaces. Yeah.
That sounds great. Yeah, we'll talk about that. Genesis, add that to our, whenever we get together as a team to talk about doing another workshop from survivorship, to do a workshop with Marleah and the folks at Force to, really disseminate this so that people can benefit from it, providers and patients alike. So
yeah, that'd be great.
Cool. Well, thanks, Marleah. Does anyone else have any other questions about Force, about the content? I don't see any, so we will let you all go. Thanks everyone for coming this morning. Next month we have, what do we have? Opioid abuse. and survivorship. So tough issues that we're addressing. So thanks everyone for coming, and we'll talk to you next month.
Thank you so much again. Bye. Have a great day.
Okay, bye. Thanks.